Thank you for those that have joined, or for anyone that might be listening to this on a recording that we'll share after the session. My name is Hannah Fox. I'm a customer success manager at Thrive, and I'm also joined by Dr. Andreas Fonseca, who is our CEO and co-founder. I'll let Andreas introduce himself, take you through the session, and also explain, why we're also interested in this topic at Thrive, especially. So over to you, Andres.
Thank you, Hannah, and thanks very much. Hello, everybody. I'm a consultant psychiatrist by background. I uh, I am dual qualified, and I'm a general psychiatrist, and I'm also an old-age psychiatrist. And in my clinical practice, I was always interested in the transition, and that led me to have developed a few different, more specialized. I'm going to call them services, although that sounds a bit grandiose for what they were. They were just that the GPs in the area where I was working, this was when I was working in the NHS, knew about this particular interest of mine and tended to refer patients to me. And one of the things that we'll talk about today is that in the menopause in particular, there's some situations in which it is psychological and psychiatric symptoms that present first. And when they do, they tend to be quite difficult to treat. And that might lead the GPs to be a bit puzzled, particularly in people perhaps with no history of mental health problems in the past. So it led me to sort of develop a particular interest and to have this kind of joint clinic where we had this population, and we looked at all the different ways in which it could present, and how to best give them a comprehensive service that both looked after obviously the mental health, which is my area of expertise, but also everything else. As you will see, it is a complex. It seems simple, but it's a complex situation, and the menopause can present in very different ways in different cases, and the natural history of it can be different. So it can present with some symptoms at the beginning and then develop the others. It's very variable. And I think that's one of the most salient messages that I want to give you, that individual differences are very important. And I have the privilege of having worked with so many patients, have had a very wide range of experiences going through the different treatments and the different options and the different situations. And I am going to address how this affects work and how work can best adapt or best support somebody who's going through the menopause. And again, there's not going to be one size fits all. I think that's one of the salient messages. It's going to be what is best for the individual, for the specific woman who's going through this. So I am aiming to cover these topics that I've got here. So it's an overview of the topic. Of course, I make particular emphasis on the possible links between the menopause and mental health conditions, specifically depression and anxiety. There's one other presentation that is also very important, and that led a lot of people, a lot of women, to come to my clinic to have a consultation about this, which is memory problems. So there's a mental fog that sometimes is described. So I will discuss the management of the symptoms of the menopause, and I will obviously pay attention to the use of hormones, very important, but also to the use of all the medication. And I will discuss many interventions that don't use any medication at all. And again, as I go along, I'll try to make references about how this does this particular thing that I'm talking about have any implications for work and for the workplace in general. So I think I'll start by just telling you a little bit about what the menopause is, because it's got a specific definition that you may not be aware of. So the menopause is the phenomenon whereby a woman who has menstrual periods stops having them for at least 12 months. And this must be as a result of changes in the levels of a range of reproductive hormones. And obviously the key hormones are the ones that I put there on the screen, as the anti-Müllerian hormone, follicle, the FSH, inhibin B, and estradiol, estrogens. Yeah. So hormonal levels change over the course of a few years before the last menstrual period. So you don't know. So you may have irregular periods, and you might think, oh, maybe this is the menopause. But strictly speaking, according to the definition, if that happens and you've got symptoms, you are in what's called the perimenopausal stage, right? So it's only after the periods have ceased for 12 months that the the definition of the menopause is met. That doesn't matter to you because you're still having the symptoms. But that is the technical definition, as it were. So as I said, they can change for a few years before this last menstrual period. The key changes that are linked to the symptoms of the menopause are a very acute drop in estradiol levels. And during the transitions, periods may become more irregular, as you might expect, and the symptoms, this is the perimenopausal phase, the symptoms characteristics of the menopause may surface, or do often surface, to be honest with you. Now, some cases, this transition lasts for a long time. In other cases, it's very abrupt. Some cases is more severe. Some cases is less severe. I'll talk a little bit about that in a minute. So it is part of normal aging, and it tends to present between the ages of 45 and 55. In the UK, the average is 51. That's the recorded average. And that has been more or less there for the last 10 years. So these are the symptoms in general. And then I'll go through each one in particular. But most women will experience, let me just make an emphasis there, will experience symptoms during the menopause. Now, there's a small percentage of women that don't experience any symptoms at all, and some experience severe symptoms that can significantly disrupt their lives. Those cases tend to be actually hard to treat as well. So there's a bit of a double whammy. So it's important to avoid over-medicalizing the condition. So this is something that is talked about. After all, people say it is associated with normal aging, and it is true. It is associated with normal aging. However, on the other hand, and this is perhaps my point, it is very important not to under-medicalize it, because we will see in a minute how big the implications are for these symptoms. So in the average case, it's worth considering consulting with your GP and discuss whether hormone replacement therapy is right for you. Why hormone replacement therapy? Because it is the gold standard, is the thing that is the most effective. And most women will be fine with it, like the great majority of women will be fine with it. So that's the thing. Now, I often hear that sometimes when somebody goes to consult with their GP, they might get dismissed, the symptoms might get minimized, or they might say that there's risks associated with HRT. They're true. That is true for a very small percentage of women, where there might be a contraindication, but for the majority, it is not contraindicated. It's actually indicated. So if at first you don't succeed, I suppose when you're having the symptoms and you're already quite, you're struggling because they can be quite severe, and you get dismissed at the GP, that might be quite a disheartening experience. In my opinion, I think it happens far less than when I started working with this now, but it still happens. So I think that's a thing. I think you do need maybe support, maybe from a loved one, from a family member, from a friend, to help you, I suppose, maintain your motivation to seek help, and also perhaps bear in mind that if you at first you don't succeed, you shouldn't dismiss it yourself. If you are having the symptoms and they're having an impact, which they often do, I think you should insist and don't feel bad about insisting. So one important thing to understand is that sometimes the symptoms can be so strong that they feel like a medical emergency, and this has happened to some of the women I've worked with a few times. That's the way it started. And I remember one particular case that was initially diagnosed with panic attacks, and they were not panic attacks. You'll see that some of the symptoms of the menopause can overlap with panic attacks, and obviously anxiety is a feature. So it can be misdiagnosed, is what I'm trying to say. The good thing about it is that the symptoms of the menopause in themselves are not dangerous. Although they might feel like medical emergency. if you do feel like it's really bad, don't dismiss it because you think, oh, it might just be a hot flush or something like that, or the palpitations that I'm feeling might be just part of the menopause. I wouldn't do that. I would still take it seriously and don't feel bad. Even if it turns out to be nothing, that's great. But you still sought help. Because how would you know? How would you know whether it's an emergency or not? Unless somebody checks, you don't know. So it's better to be on the safe side and check. I think that's very important to understand. Now, I'm just going to break it down. So these are the vasomotor symptoms. So these are the most frequent symptoms, and I've got them at the top there. So the vasomotor symptoms is like an umbrella term for the hot flushes and the night sweats. They are related, obviously. They're likely caused by the decreasing level of estrogens during the menopause and their effect on temperature regulation that we have in our, there's a thermostat, if I can explain it quite simply, in our brains that regulates body temperature, and that is in part regulated by the level of estrogens. And I think you will know what I'm talking about because you can track your temperature, your body temperature through the menstrual cycle. And with that, you can more or less predict when ovulation happens, right? So you know that there's a link between the hormones, the hormone levels, and during the cycle, and temperature and body temperature. So what happens is when those levels fall off a cliff and they're not there anymore, the whole system seems to become hypersensitive. So small fluctuations in body temperature activate abnormally all the body, all the mechanisms that we have in our bodies to get rid of the excess heat, and they are triggered inappropriately. So they shouldn't have been triggered. So these mechanisms, of course, include sweating, and also this is the vasomotor component. Vasomotor means that the blood vessels are moving. What do you mean that the blood vessels are moving? They are opening and closing. That's what it means. So the little blood vessels in your skin and throughout the body and in your face, those are called capillaries. They are controlled. They have a little muscle that controls them, that opens and closes, right? So it opens when it's trying to get rid of excess heat. That's why you go red when it's very hot, or when you're sweating, or when you're doing exercise. And they close down when it's very cold to try and present cold temperature. So those are the mechanisms, right? So that gets triggered inappropriately. Everything opens up, and you feel like, this creeping feeling of intense warmth. It's like real heat that quickly spreads throughout the whole body and face. And some women describe them as feeling like you might have been in a sunbed, maybe for too long, or feeling like a furnace. Those are the things that I've heard it described as. And sensation tends, I think it's also different from the repeatedly asking about this. You get slightly different experiences and slightly different descriptions depending on the individual. I can tell you that is extremely unpleasant, and some of you in the audience will know from personal experience what I'm talking about. So the sensation tends to last for several minutes, and again, it can be quite distressing, and it can be quite disconcerting when you're trying to concentrate. You're in the middle of a meeting, or you are doing something. You're going about your business. It might actually stop you in your tracks, and you need to sort of get out of the situation. And again, this is something important for work, that one needs to understand that sometimes that is important to allow those breaks, or that ability to sort of go to the bathroom to sort of freshen up. That kind of a thing needs to be understood, that it can happen. And it can last for several minutes, as I said. So women who experience night sweats describe waking up in the middle of the night covered in sweat, even though the bedroom is cool and they're wearing appropriate clothing, night clothes. The amount of sweat is enough to soak through the night clothes, and also their bedding. So it's actually quite extreme. As I said, they seem to be linked with this temperature regulation, and there's a couple of studies that, if anybody's interested to know how that link was made, we can facilitate. I don't know if anybody's interested. I'm a bit of a nerd for these things, so I do read the mechanism papers myself. But yeah. If you don't want to, I don't blame you. Poor
We've got
sleep.
a few questions, Andreas. Do you mind if we answer those
Yeah, I
quickly
mean,
before we
I
move
could
on?
stop there or do it at the end. Yeah, we could stop there if you want.
We've got one asking whether the symptoms that you've just described are the same for perimenopause.
Yes, they can be exactly the same. Yes, and the intensity can change throughout the history, the natural history of the progression of the condition. Yes, the ones that I'm going to describe now as well. The other thing to understand is that sometimes they don't necessarily present all at the same time. That they can change throughout the presentation. They can be more intense. Some can disappear. Some can reappear. So even through the perimenopause, that's what I was saying. I had a few women in my clinic that had presented initially with maybe panic attacks. They were misdiagnosed panic attacks. Sometimes it was depression, and it wasn't. Well, it was. There was a component of low mood, of course, and that needed treatment, but it was misdiagnosed as being just depression without paying attention to the menopause. Sometimes it's anxiety. These things can happen. So yes, the symptoms that I'm going to talk about can present in the perimenopause, and it can confuse the diagnosis if you're not paying attention. Yeah. Yeah. So poor sleep, very, very strong link to the previous symptoms, which means that if we take care of the previous symptoms, we tend to take care of this problem. Now, it can be quite a serious problem, and it can affect all aspects of sleep. So it's getting to sleep. So that's initial insomnia, it's called, waking up many times in the middle of the night, and waking up too early and being unable to go back to sleep, which is also characteristic of depression. And again, it can be confused and it can lead to the wrong conclusion. So the reason it's so important is because sleep, for example, if you have poor sleep, you tend to have poor memory, like we're going to see in a minute. If you have poor sleep, you tend to be more at risk of developing depression, of developing anxiety. If you have poor sleep, you can develop obesity just caused by the poor sleep. More of this mind fog, which is going to affect your work, obviously. It can lead to sleep apnea because of the obesity, and then worsen the sleep problem. It can lead to diabetes. It can lead to an increased risk of cardiovascular problems. So sleep deprivation is really not trivial, really, really not. And is on its own. If if we take nothing else away, this is very important. The fact that these vasomotor symptoms can affect sleep, apart from doing all the other problems that they cause during the day, this is actually quite a crucial thing to try and solve. You need to sleep well. It's very important to your overall health. So yeah. Low mood and anxiety, as you might expect, is quite common during the menopause. And in some cases, as I said, it can present before the menopausal symptoms start. So in the perimenopausal period, you can present with these symptoms without very much in the way, or maybe you're not noticing very much the vasomotor symptoms. In other cases, it happens at the same time. So when they happen at the same time, we believe, and actually there's some good evidence about this, that it is the vasomotor symptoms that may cause the mood symptoms. And it might be through the lack of sleep, as we said before. So when you treat the vasomotor symptoms successfully, the low mood tends to resolve. So you don't need to treat it on its own accord. Everything can be treated together, and it works, and it's good. However, there is good evidence that it is also possible that the drop in the estrogen levels is directly responsible for the mood changes, like in these cases where they present first. And that has some implications for treatment. I think the answer is probably both situations conspire to make it more likely for women going through the menopause to be affected by low mood. However, I think the difference is important, and knowing what happens first and what happens second is important when you're trying to do an effective treatment. I think it's important to take into consideration. So specifically, the risk of anxiety seems to go up by 60%, so 1.6 times, and the risk of depression goes up much more, so 2 to 4 times higher, so 200 to 400% risk, which is very, very significant. Now, this leads me neatly onto this one, which was, as I said at the beginning, this was one of the main reasons I had people come to my clinic, because I told you I am dual qualified, general psychiatry and all the psychiatry. All the psychiatrists are very concerned with memory and memory problems, and because the GPs knew that I had an interest and an expertise, I had a lot of women refer to me during the menopause or perimenopause with this concern, with memory and concentration problems, which obviously were affecting their work. And again, this is important to understand when we're trying to make reasonable adjustments, that you may not be able to take in information, you might not be able to remember information, and that needs to be we need to understand how this affects your work and what can we do to improve it while we're seeking another solution, while we're doing the treatment. This may affect you for a while. Yeah. So many women report this. It is very frequent, as I have called there. The good news, it is temporary. It is characterized by pro-new learning ability, as I've called there. Now, the good thing is that the period after the menopause, which can last for quite a while with still symptoms, so the postmenopausal period, the effect seems to disappear after the symptoms completely resolve. We think it's linked to the sleep problems and mood problems that we've already discussed. You know that in depression and anxiety, it does affect cognition. So again, we know that if we resolve the vasomotor symptoms and the other symptoms and we get good sleep, this is also tends to disappear as well, tends to be treated. So again, I go back to the causal chain seems to start with the vasomotor symptoms, the hot flashes and the night sweats, and cause all kinds of other problems downstream, as we're seeing. Now, vaginal dryness and discomfort during intimacy is an important symptom, and this is quite frequently experienced during the menopause. I mean, with the vasomotor symptoms, is probably at the top of the symptoms that tend to present. This one is actually perhaps the best understood, as you can really plot estrogen levels against the normal regulation of how vaginal secretions are maintained, and obviously with those you maintain the appropriate environment. If you don't, when that doesn't work, when that is that starts not being as well managed as it was before, you have an increased risk of developing water infections and other kinds of infections. So it is actually very important for all kinds of reasons to get this right. I mentioned other symptoms that may happen. Headaches and joint pains are also frequent during the menopause, and pain can also lead to poor sleep. So it's important to sort of make that link as well. Also, like this lady that I was working with, who was diagnosed with panic attacks, you can have bouts of noticeable heartbeats, palpitations, that can actually feel like your heart is giving up, or there's something wrong with your heart, or that the heart is beating irregularly, and they can be very disruptive in themselves as well, and quite scary. So palpitations, this noticeable fast heartbeats, can be a presenting symptom. The symptoms can start months or years before the periods stop, and they can last around 3 or 4 years after the last period. So it can be quite a prolonged period of time. So some women can have them for a much longer period of time. I do tend to get a question about treatment duration, but I think I'll address that later. So how do we manage the symptoms? So before I go any further, I do want to make clear that women experiencing these symptoms, I mean, again, this was an issue maybe more earlier in my career than now, but many women were telling me that perhaps they should endure them and wait for them to like diminish. As I said before, this can be years, so it's a bit difficult to swallow this, for me at least, to swallow this pill. So maybe they should endure them, and it is part of normal aging. So why are we doing this? I think they can be extremely distressing and disruptive They can affect other aspects of health, like I outlined. Sleep problems by themselves, as I think I pointed out, can increase the risk of various health conditions. So if the symptoms are troubling, I think it's definitely worth talking to the GP. The other thing that I would say is that if these symptoms, even if you think it's the perimenopause and you still have maybe irregular, maybe regular periods, if they start before the age of 45, it's a good idea to consult your GP. Why? Because it might not be the perimenopause. There might be other reasons why the symptoms are being caused. So before the age of 45, these symptoms may be something other than the menopause. So it's important to know that as well. Okay, so what are the treatments? So I'll start with obviously with hormonal treatments because they are the gold standard, and it is the number one treatment is hormone replacement therapy. So there's various forms in which it can be administered. It can be an estrogen plus progesterone, depending on your individual case. In some cases, estrogens alone is fine. Some cases it does need the progesterone, and it can be given as tablets, gels, patches, or even implants. Okay. I am not an expert in the hormonal treatment. I always did this in partnership with the GP. When I felt that the treatment was not about me doing anything or me prescribing anything directly, that we needed to do HRT first, then I always did that in partnership with the GPs. So specifically for vaginal dryness, estrogen creams and water-based lubricants and moisturizers can be used successfully, but I would say something that is important to avoid: perfume soaps or washes and things like that. Creams and lotions that may not be appropriate need to be avoided because they can increase your risk of infection. I think that's important to bear in mind. If moisturizers are used, they need to be specific for vaginal use. And there are some that are, again, I would ask my GP, I would ask the pharmacist as well to see what the best use is. Okay, these are not hormones that we can use in the menopause mainly to control hot flushes. So some women cannot or do not wish to use HRT. The number one treatment in this case as an option is this class of antidepressants called selective serotonin reuptake inhibitors, SSRIs, and they have shown to be effective in reducing vasomotor symptoms. These medications work by increasing the level of a neurotransmitter. A neurotransmitter is like a chemical that brain cells use to communicate with one another, basically. And this neurotransmitter is called serotonin. And these medications that have names like paroxetine, fluoxetine, sertraline, increase the level of serotonin, and they seem to be directly counteracting the reduction in serotonin levels that follows the decline of estrogen levels in the menopause. So somehow, and again, this is not completely well understood, we see a declining level of estrogens, and we also see a declining level of serotonin. Now, because the brain works in a very interconnected way as a network, when you upregulate the serotonin, you seem to get better temperature control, and you do seem to sort of see a reduction in the frequency and the severity of the vasomotor symptoms, the night sweats, and the hot flushes. In addition, of course, they can be useful to treat depression and anxiety associated with the menopause. But that's not the main objective. The main objective when introducing them is to try and see if they resolve the vasomotor symptoms. An alternative to these is gabapentin. So gabapentin was created in the first place to treat epilepsy, but they have this regulatory effect. So what they do in epilepsy is they have an effect on the calcium channels in brain cells, and what they do is they improve their function so that they're less likely to misfire, and that's what leads to perhaps the epileptic crisis. So they're less likely to misfire. This seems to also apply to the menopause. I told you that you've got this thermostat, it's on a knife's edge, and this appears to make it stop from misfiring so much. And the evidence is quite good that it reduces the frequency and severity of the hot flushes and the vasomotor symptoms in general. I've got there pregabalin because pregabalin is a similar drug, but there's far less evidence for it. So it's only used if, for whatever reason, gabapentin cannot be used, and it's not recommended at the moment because lack of studies, not because it may be helpful, but it's only in selected cases. Clonidine is a medication that is normally given in high blood pressure to treat high blood pressure. And what it does, it stops the hot flushes by stopping the small, tiny vessels. I told you about these tiny vessels that open up unexpectedly and at the wrong time that give rise to the hot flushes. It stops that from happening. However, clonidine has some undesirable side effects and is very uncommonly used. It's only in very, very selected cases. We also have oxybutynin, which used to be like a novel treatment when I first started looking at this, and now it's actually quite established. Oxybutynin is a tablet normally given for urinary incontinence, and there's been quite a few studies now showing that it can be effective in both healthy women and breast cancer survivors. I think this is robust, and particularly more recent evidence that seems to support what we saw in early trials. There's a new, I don't have it on the slide, but there's a new class of non-hormonal treatments that were specifically developed for vasomotor symptoms, and they are the neurokinin 3 receptor antagonists, NK3As. And there's one called fezolinetant, that has been approved in the US in 2023 by the FDA. It is under review currently in the UK. It's not yet approved, but the papers, the studies done on it seem to be very promising, with good side effect profile and good effect on the vasomotor symptoms. So that's one option perhaps for the future that should be coming on in the next year or so, if it goes through approval. Then we also have new medications that were approved for sleep deprivation. They're called suvorexant and daridorexant. They don't do anything for the vasomotor symptoms, but they do improve sleep. So maybe if there's no other option and you do need to treat sleep, these might have a role. And I also get questions about CBD-based drugs and CBD approaches, and they tend not to be effective. That's what I can tell you. The trials have been negative for those approaches. So these are non-pharmacological interventions, so meaning we're not using any drugs to treat here. So weight loss can be very effective for some women, as there's a higher risk of having vasomotor symptoms in women with a high body mass index. Of course, there's other benefits from losing weight, such as improvement in sleep and improvement in joint pain and stiffness. So that link is fairly clear. The one that is very solid is exercise. In the latest 2023 guidelines that were published for the management of vasomotor symptoms in the menopause, endorse exercise, with the highest endorsement, and it reduces the severity of the hot flashes, and it also has demonstrable benefits in pain, in depression, and obviously in sleep. So that's worth bearing in mind. Okay, what about herbs? This is again a very frequent question that I get, and I put there some of the ones that have accumulated some evidence. And actually, there's a study, I think it was this year or last year. I think it was this year, that combined isoflavones with black cohosh with some positive results. But anyway, there's some evidence that isoflavones, purified pollen extract, may show some benefits. What is important to know about the isoflavones is that they have properties that make them behave very similar to estrogens. So for those women for whom HRT is not recommended, also this is not an option for the same reasons, right? There's also some evidence for black cohosh, and there's evidence for this combination that I told you about. Okay, the problem that we have with them is that there isn't enough, even with these small trials that I'm mentioning, there isn't enough evidence to recommend them, because the research is patchy and yeah. But also the products are not regulated, so it's very hard to know exactly. So if you buy a packet of whatever, it's very hard to know exactly what is in that remedy and what is the relative dose and what are you taking exactly. So they can also interfere with some of the other medicines. So if you don't tell your doctor, there might be interactions that happen and we don't know about them. Also, they can have their own side effects. For example, black cohosh has been linked to liver damage as well. So, should we use them? Should we not use them? There are some physicians and also some specialist nurses that do know about these very well. They do know the market. They do know what's out there. Under their supervision, I think it's a reasonable thing to do, if that makes sense. I think it's reasonable to use them, but I wouldn't do it on my own, and I wouldn't just buy the thing that you saw in the shop. Why do I mention acupuncture here? I mean, it's not a herbal remedy, but I mention it together with this because I want people to know that it's not been shown to be any better than placebo. It says completely ineffective. I think I'm being harsh there. Placebos are very effective. Placebos are good. However, the problem with acupuncture is that it is an invasive procedure. It is about putting needles through your skin. So that has its own risks. So I don't think that risk-benefit analysis works in the favor of acupuncture. It's not better than any other placebo, than an equivalent placebo. Therefore, use a safer placebo. What is a safer placebo that can work and can be helpful? Reflexology, for example, kind of based on similar principles. Is a nice massage, and it can be some people report it being very helpful. It is a placebo, but it's a placebo that doesn't have any risks associated with it. So long as you also seek other help, and it doesn't prevent you from accessing the right treatment, it can be helpful, and it can be effective, and some people swear by it. I am okay with it because it's not likely to cause harm. So that's my thinking. So what are the psychological interventions that have shown to be working? So I've highlighted 3 there. There's 2 that are more important than the others. So CBT and applied relaxation, and I'll explain why. There's a comprehensive review that has been happening every few years on this more psychological. They're also called mind-body interventions. Because, for example, in some of those reviews, so the first one that I know about that was comprehensive and good was done in 2017, and then there's been subsequent ones that have found more or less the same thing. I reviewed the latest one, and again, it's more or less the evidence seems to be exactly what was there in 2017. There's no new information there, so it seems to be very solid. So yoga is one of the ones that is touted out as being useful. I would say definitely is useful. Why do I say it's definitely useful? Because it's exercise. It doesn't seem to be any better than any other form of exercise, but remember, exercise is excellent. So it's great. So if that's your preferred form of exercise, fantastic. What about relaxation in general? Relaxation seems to be helpful, but only during training, and the effects seems to wash off, with the exception of applied relaxation. Applied relaxation is a very deliberate training that you do. You have to do this training program, which lasts a few weeks, and at the end of it, you do gain quite a lot of control over your what we're going to call your relaxation response. So applied relaxation, it is a form of relaxation. We will offer it very soon in the Thrive app, and it's been shown to be beneficial. It reduced both the frequency and severity of vasomotor episodes. When you look at follow-ups, the severity was sustained, and the frequency was the same. But if you do retraining, that seems to work. So if you revisit the training program and you top up, it seems to continue having an effect. Mindfulness or meditation-based stress reduction was effective in the control of the severity of episodes, but not their frequency. The effects tend to wash out pretty much immediately. So again, maybe regular practice can be helpful. we include these exercises in the Thrive app. It's not there on the slide, but hypnosis and self-suggestion techniques, this is emerging evidence. They seem to be good in the past, but more recent trials seem to actually highlight that they can be extremely beneficial, but not for everybody. There's some people that can make better use of these than others. So it's worth trying because it's not harmful, it's not invasive, so it's worth trying. But recent trials suggest that this is a good intervention. We do include this technique in the Thrive app under the level self-suggestion. So these all of these techniques have also the advantage that they are helpful in anxiety and also can be helpful in sleep and sleep improvement. Lastly, we've got CBT, and I leave it for last because it's the most powerful of the lot. Trials have shown, and this is repeated trials over time, have shown a good reduction in the symptoms during the training, at 12 weeks after the training and at 6 months after the training, with no need for top-ups or anything like that. And obviously, the other advantage that this technique has is that it can be applied to depression as well as anxiety and also sleeping problems. And we have in the Thrive app a comprehensive CBT training program. It is a generic CBT training program, but it can be adapted to specific situations, quite easily. So, what can we do as employers and colleagues? I think this is very important. I think I've highlighted a few things while I was giving you the information about how it presents and how to treat it. Basically, my advice stems from that. Yeah. So, what big thing? It can present in very different ways. The cause can change over time. Yeah. So we need to have this open dialogue and not make any assumptions. You may have experienced the menopause yourself, and your experience might be very different from the person that you've got in front of you. You may have had very little symptoms or no symptoms, or you may have had tons of symptoms or different symptoms. So it's important to have an open dialogue and active listening. It's important to validate their feelings. The person that's going through it knows best what's happening to them. So that's important to understand. I think that's obvious. My driving message is acknowledge the individual differences. I don't think we can have a box that says we deploy this in case of somebody is experiencing or going through the menopause, and we do exactly the same thing for everybody. I think we need to be quite flexible. We need to acknowledge those individual differences, and we need to sort of think carefully about what reasonable adjustments are. And this may be different for different people. So you may propose time off, and the person might not want time off. You may propose frequent breaks, and that's not what solves the problem for the person. So you do have to take into account that because it might be difficult to treat, and because we may be doing CBT, we may be doing all of these other interventions, people may need time off to go and see specialists, to go and see doctors, and to have the treatment adjusted. And that can take some time. So that needs to be acknowledged and taken into account. Also, it may work, it may not work. So there might be a period where we're going through the treatments and we're seeing whether they are having an effect or not. And again, different people respond to different things differently. And you saw all the different potential interventions that there are. And again, it's not clear. So we have what works for most people, but we don't know what's going to work for the person in front of us. So that all needs to be taken into account. What I'm trying to say is that we need to individualize the response, think about the individual, listen to what they're telling us, seeing what their needs actually are, respond flexibly, and do those reasonable adjustments. I think that's what I can say about this. And remember that it can affect sleep, can affect concentration. So what do we do? What do we need to do to improve that and to support with that? So my summary is that the menopause presents in very different ways to different women. Some women experience severe symptoms that interfere with daily lives. Others only have very mild manifestations. This is a minority, I must say. It's important to seek help and not to endure the symptoms unnecessarily, because they have other health implications, as I hope I persuaded you. And I would recommend that the threshold for a consultation with your doctor should be quite low. And if you feel that you're getting dismissed, get some support and insist. I'm sorry, but or ask for a different doctor. Or ask for to see a different doctor that perhaps is more knowledgeable about this. I've got a paper recommendation because I like it. It's well written and it goes through all the mind-body interventions. Is the 2017 paper, in case anybody's interested. But I do have this book recommendation, and I do recommend it. Estrogen Matters and Why Taking Hormones in the Menopause Can Improve Women's Well-being and Lengthen Their Lives. So it's written by an oncologist and by a social psychologist who go through the history of why this idea that they are very risky and they can cause cancer in most cases. How did that came about, and what the actual evidence is, and why we should not take into account. Other things that I mentioned, just so we remember, the hormones are the number one treatment unless they're contraindicated. But there are some no hormonal treatments like SSRIs, in particular. Weight loss and exercise, very good. Yoga is no better than any other exercise. Herbal remedies, they have to be used under supervision of somebody who knows what they're doing, and CBT is quite effective, as is applied relaxation and also self-suggestion hypnosis. I think I'm going to hand over to my colleague Hannah now.
Thank you, Andreas. Hi again, everyone. I'm just going to quickly run through just the different elements of the Thrive app, and then we're going to head back to your questions, because I see there's quite a few questions that have come through. So I'll quickly run through these, and then we'll answer your questions with Andreas on the topic as well. So a bit about Thrive and our solution for those of you that don't know what it is or don't know too much about it. We are a human and digital expertise. We are a hybrid model, so that means that we essentially combine using digital tools with that human knowledge as well. So that's the knowledge of the therapists that we have within our service. So the reason that we do that is because a digital only solution, it lacks that impact of having that qualified clinician with you to create those outcomes. But also having a therapist only solution means that you are kind of missing out on those digital tools as well. So bringing them together can really help to promote the best of both. So we were co-founded by Andreas and Adam. Obviously, you know Andreas from being on the call today, but Adam as well has just as much experience, and both of them very passionate about supporting and reaching kind of as many people as possible, and recovering those people from any symptoms that they might be displaying. Just a little quote there from our lead therapist, but essentially reinforcing what we're saying, in that we believe that therapy should be within reach. There shouldn't be any kind of blockers to accessing support that you need to access, regardless of your location or any different circumstances that might be preventing you from accessing that support. And that's really why we offer our service, to ensure that people can access that support that they need. So what do we do differently at Thrive? So we have that proactive support from a therapist, which I'm going to show you how that works with a very short video in a second. So when someone does present with some symptoms of being unwell, we do proactively reach out and support that user. Early intervention. So we want to prevent minor issues from becoming major issues, and we do have very high rates of help seeking within the service. We do offer our therapy based on clinical needs, so there's no kind of cap on the amount of sessions that you are offered. We want to be able to offer people sessions up until that point of recovery. And because of that, we do have a really high recovery rate within our service of 86% currently. And to add a bit of context to that, the NHS equivalent is usually about 50 to 55% recovery rate. So yeah, we're really proud of our recovery rates that we're able to offer our clients and people that are using the Thrive service. So I'm going to try and play a short video just to show you what the screening process and proactive intervention really looks like within the app. So when you first download the app or when you first open up the app for the day, you're presented with a short assessment to answer. We would recommend to take these assessments fairly regularly to keep on top of your mental health, the same way that you would, do things like eating healthily or going to the gym to try and keep on top of your physical health. It's always good to check in on your mental health as well. So you can do that by answering this short questionnaire. It's using clinically validated tools, the PHQ and the GAD questionnaires, and they're the same questions that if you were to go to your GP, for example, and mention that you were struggling with your mental health, they would ask you these same questions. So the user in the video is kind of going through, answering the questions on how they're feeling, and then they're shown how they have scored. And from that point, we move on to the therapy and chat service. If I can move the screen. There we go. So from that point, someone, if you are screening positively for anxiety or depression, a therapist will proactively reach out to you within 10 minutes. So it's a really quick reach out, and you're able to then at that point be assessed to whether you need to go on to have some therapy sessions. And then we book those therapy sessions in line with clinical need and with the aim of recovering the individual. You don't have to take the assessment. There is a chat button within the service as well. That means you could start a conversation with the team sort of without having to go through the questionnaire. If you know you're struggling, if you know that you need help, you're able to do it that way as well. So as Andreas mentioned, the Thrive app isn't all about therapy. There's lots of tools and techniques within the service that can help with any feelings of stress, anxiety, panic, but also symptoms of the menopause as well. So obviously we spoke about CBT. We've got the full CBT course within the service, meditation. We spoke about applied relaxation as well. That's something that's being relaunched within the app very soon, and is a really effective way to kind of deal with those symptoms of menopause as well. And lastly, how can Thrive actually help you? So it can really help to manage any kind of milder mental health conditions, support that therapy treatment journey, speed up your recovery, and improve things like your sleep, daily habits, manage your stress, and just help you to kind of learn more about your mental health, your mind, your body, etc. as well. So that's it from me. But I know we've got a lot of questions in the chat, so I'll start reading some of those out for you, Andreas. One of them that came in was, can we touch on premature menopause and how best to push back with GPs who think that we might be too young to even bring up the possibility? And if there's an increased risk for women who enter into the menopause in their mid-30s?
Yes, absolutely. So that's what I said at the beginning. So if it happens before the age of 45, it may not even be the menopause. Just to see what I mean? So those symptoms can appear in other conditions. And actually, it is more, it's important to seek help, even if you're over the age of 45, if those symptoms are significant. But if you're younger than 45, if it's in your, particularly, somebody in their 30s, for sure, you definitely need to seek help, because it might not be the menopause that is causing the problem. It might be other things that are causing these symptoms, and those need to be investigated, and investigated quickly, because you may need treatment in short order to try to get to the bottom of it. So yes, you can have early menopause, but very, very importantly, It may not be that is causing very, very similar symptoms, and one needs to get to the bottom of that very, very quickly. So definitely don't let the GP dismiss it, because it might not be the menopause, and they should know.
Thanks, Andreas. How long do symptoms last for surgical menopause?
Surgical. So if you had to, I mean, again, it's highly variable. So the change is much more abrupt, because obviously there's been that surgical removal of the ovaries. So the period of adaptation or the transition can be harder. But again, the cause is very variable, and it depends very much on different people. So again, it could last months, but it could last years, as in the case of like the standard menopause, as it were. You have to sort of look at what the person is presenting with and address those symptoms. And again, even if you had a surgical removal of the ovaries, for whatever reason, the care plan has to be individualized to your needs rather than making assumptions. So you need a thorough assessment about how to best deal with it. Yeah.
Thank you. How does being on the estrogen-only contraceptive pill impact not only the symptoms of perimenopause, but also the development and process of it in general?
Yeah, so in some cases it's indicated to just be on the estrogens. There's no major differences. When it's indicated, it's perfectly reasonable and safe. Obviously, it has to be supervised by somebody who knows what they're doing, what they're prescribing. And there isn't any. So again, there's no prescribed duration of treatment either, if you know what I mean. Again, you need to adapt it to the individual case. What you're trying to do, really, overall, is you're trying to, at intervals, withdraw the estrogens, maybe slowly, but sometimes you have a recurrence of symptoms, and then it's really not worth trying to eliminate them for the sake of eliminating them. What you really want to do is to do a very slow, gradual withdrawal that does not generate symptoms. This applies to whether you're on estrogens alone or whether you're on estrogens and progesterone. Some people even take a little bit of testosterone as well for various reasons. So yeah. So I mean, I don't think there's anything specific about estrogens that changes the approach, other than your individual characteristics and why estrogens alone were felt to be the best option. Yeah.
Thank you. Can symptoms be worse mid-cycle, or would this be constant based on reduced estrogen?
No, it can fluctuate. So, and as I said at the beginning, you can have a different collection of symptoms at the start, and maybe it improves, and maybe then it worsens. Again, what I think this will explain it. So what's happening here is that they do rapidly decline, and the rate of decline of the estrogens again is variable. So there's no one size fits all even here. So it is rapid, but the rate of decline can change. So how steep that curve is can change, and there's a little bit of adaptation or trying to compensate that happens through this process. So you've got these hormones that are secreted in the brain that stimulate the production of estrogens. Yeah, so it's regulated in this way. So the estrogens regulate what happens in the brain, but the brain regulates what happens in the ovaries, right? So there's the two-way street, as it were. So if I'm not getting enough estrogens, then I'm going to try from the top, I'm going to try and stimulate the production of more estrogens. And that can sometimes rescue some of that production of estrogens, if that makes sense. So you stimulate, so it's declining, but you stimulate it to produce more. And it works for a while, and then it declines again. So you may be better and then worse, and better and then worse, because you have this difficult to adapt to situation where there might be these fluctuations in levels, this fall and rise and fall, that makes it harder to adjust to. Rather, you don't necessarily see what you expect to see, which is just a very smooth decline or anything like that. Even if it's rapid, it's not smooth, if that makes sense. And that's why symptoms can change. through the course of to the course of the perimenopause, menopause, and postmenopausal periods.
Thanks, Andreas. We've got a few more questions. Do we have time to carry on?
I do for a bit. Yeah.
Yep, perfect. Is it true that perimenopause can start anywhere from 10 years prior to the menopause?
It can do, again, if you have perimenopausal symptoms before the age of 45, I would take that seriously, if you know what I mean. So it can do, and it can be perfectly fine, and it could, okay, so we study it, we do the test that we need to do, and we conclude that this is the menopause. That's fine. Well, it's not fine because you're having the symptoms and you're having them from early on. But nonetheless, I wouldn't dismiss it. I wouldn't say, oh, it's just the menopause and I'm a bit early, if you know what I mean. Now, yes, I mean, let's imagine that you are going to have your last period when you're 55. Could you start with perimenopausal symptoms at the age of 45? Yes, that's possible. It's rare, but it's possible. It's less concerning because it's after the age of 45. But nonetheless, again, depending on how those perimenopausal symptoms are, nothing stops you from seeking a consultation, and don't let people dismiss you.
Great, thanks. Might get the pronunciation wrong on this one, but someone taking fluoxetine could potentially
Fluoxetine,
see
yeah.
less effects of the menopause.
Yeah, so fluoxetine is one of the SSRIs that I was talking about at the beginning. And there is that mechanism whereby when estrogen levels decline, we see a decline in serotonin levels as well. And these drugs, what they do is they basically, so the brain cells in the normal process, they secrete the serotonin to try and boost that signal. And then that serotonin gets destroyed, gets reuptaken into the cell, gets reused, gets recycled. And that happens very quickly. What these drugs do is they stop that recycling process from happening so that the serotonin remains a bit longer in the, basically casts that signal, boosts that signal a bit so that the whole network is upregulated. And because it does lack that input from the estrogens, that upregulation seems to then result in a better control of this thermostat that we were talking about, apart from being helpful for the treatment of depression and anxiety. So yes, that is what the trials show, that SSRIs in particular, apart from the other two drugs that I mentioned and the one in development, seem to be helpful for that reason.
Thanks, Andreas. In women who are estrogen dominant, there is growing evidence, more in the Canada or the US, based on treating only with progesterone in menopausal women. Do you know much about this? And should those who can't tolerate estrogen in that case attempt to implement herbal remedies if they have exhausted all the medical ones?
Yeah, so I mean, again, remember that there's non hormonal options as well, apart from the herbal. And the herbal, I'm not saying don't, I'm saying do it under the supervision of someone that knows what they're doing and knows the products that are in the market very well. That's what I'm saying. So I mean, again, I'm not an expert on the hormonal side of the treatment. That, as I said, in my clinical practice was done by my medical colleagues. So yes, there are in some cases a progesterone-only treatment might be indicated, and that would be determined by those who know what they're doing with the hormones. And I wouldn't be able to comment on that. I wouldn't have the expertise to do that. Now, I would have the expertise to use things like the SSRIs and the gabapentin and all the things which I've used in this context, and they can be helpful. And as I said, I wouldn't have the expertise to use the herbal remedies because it is complicated. In terms of not knowing what they do or what they don't do, even though the evidence is a little bit scant, is more about if I recommend this. Let's say that I recommend isoflavones for whatever reason. In this case, I wouldn't because it doesn't match what the question is asking. But let's say that I recommend whatever it is that I recommend. I wouldn't know whether the packet that you buy has the right dose and what dose. I wouldn't know. So that's the thing to bear in mind with herbal remedies. Yes, but under the supervision of somebody who knows what they're doing.
Great, thank you. We've got three more questions, but then I
Okay.
think we will look to wrap it up. First one, what advice would you give surrounding exercise for menopausal women who are experiencing extreme fatigue and muscle weakness? It often feels like I'm moving or walking through mud every day.
Yeah. So this is actually not that uncommon and is what makes that recommendation for exercise difficult. Now, the evidence suggests that if you are able to motivate yourself to do some exercise, paradoxically, your energy is boosted rather than declined. So my advice is to do as much as you can. Don't feel guilty about not like having a perfect program with all the goals met and everything else. If you can only go for a short walk, that's good. So, but try and build it up gradually over time. And even though you feel drained, and of course it's quite hard to motivate yourself, um, again, sometimes you will see this when we try to implement exercise in the treatment of depression alone. It's quite hard to get people to get motivated and they feel very drained of energy. But the evidence suggests that if we do manage to get there in some kind of way, and sometimes that is done with the work, with the partnership of a good therapist, finding techniques about how to overcome this lack of motivation and this lack of energy, we do get boosted energy at the end of it, and we get very good results. So there's a whole program that is based on just pure activity for depression in people who feel that they don't have any energy and they feel tired all the time and they have no motivation. So it's very common in depression. It is called behavioral activation. Now I don't know of any trials for behavioral activation in the menopause, but I bet you those techniques will yield good results when you're having trouble to motivate yourself to do exercise, because that's the whole point of that kind of treatment.
Great, thank you. How can I approach a conversation with an employer that is dismissive and not particularly supportive when it comes to how menopause symptoms are affecting me at work?
Yeah, that's terrible. That's terrible, and I'm really sorry to hear it. That's going to be a difficult one. I mean, I think are there any people that do understand what you're going through and that do share your concerns, and that you can enlist as allies? Because you're probably not the only person who's struggling with this employer. And is there any way for you to sort of organize yourselves and actually bring the matter to HR or to other managers, or to try and start establishing that dialogue? I mean, use my lecture if you want, or bits of my lecture to try and persuade the management. But yes, I know. I mean that I'm really sorry to hear it, and I know that in some places it does get dismissed, and it shouldn't be, because it is, as I said, it can affect all aspects of your health. So that's what I can think of is can you enlist the support and help of some other people at work that may be going through the same, and maybe together you can bring this concern to the attention of the people that need to be concerned with it.
Thanks, Andreas. Final question for today. How do we manage menopausal fatigue in the workplace, as many women have not yet had a formal diagnosis or they are waiting on prescriptions?
No, absolutely. I mean, this is, or they may never be eligible for a particular prescription, or the prescription might not work, right? So there's very, very many scenarios. So I think it needs to be highlighted to the managers, and this is what I was saying about that flexibility and that being very, very personalized. Um, it does need to sort of go through that. What are reasonable adjustments given the circumstances? And is part-time an option? Are frequent breaks an option? What are the options? What can we do to sort of go through this difficult phase? And it might be a phase, because then in the end you might get the right treatment, but it might last for quite a long time, as we've heard. And it's I think before the seminar, Ella was telling us about a statistic that many women that go through the menopause, when they don't have support from the workplace, then they end up like quitting their jobs, and that is a huge loss of expertise and institutional knowledge for organizations, and a huge loss for the rest of us. So I think the statistic that she quoted is up to 40%, which I mean, I'm not surprised if you don't have colleagues and managers that understand this, yeah, it's a real problem. So yeah, I mean, I think you need to sit them down, talk to them, and explain exactly what it is that it's better to know exactly what you feel the reasonable adjustments are, so that they have something concrete to act on. Um, and again, it's not one size fits all. Just think about what would work for you, and go for that. Yeah.
Great, thank you. And thank you so much to everyone for joining. You will receive a recording of the session to your email, I believe, next week. So look out for that if you want to revisit any of the topics that we've covered. But thank you again. Thank you, Andreas, and I hope
Thanks very
everyone has
much.
a great
Thanks for your
weekend.
attention. Thank you.
Bye, everyone.